introduce Dr. Disha Agarwal. It's a great pleasure to introduce to you all. And this is the second time she's coming here. Welcome you, Disha. And a brief introduction about her. She has completed her one-year mastership program on biomimetic restorative dentistry by Dr. David and Dr. David Alleman. And she has attended various certifications under the guidance of eminent and reputed dentists. She is the member of the Academy of Biomimetic Dentistry. She has various publications in national and international journals, and she has a private practice where she practices biomimetic restorative dentistry exclusively and is actively documenting the cases. Welcome you, Dr. Disha Agarwal. Over to you.
It's a pleasure to be back to the college. I didn't know in April that I will be coming back with my mentors here again. So, yes, Devi, it's not just you who got the papers, huh? I enrolled. Sorry, I'm having a little bad voice today. I hope you can forgive me for that. Yes, so it was June 2020 that I messaged Dr. David, that I want to enroll and I want to learn more about the subject and I want to learn bonding. I didn't know what I was getting myself into. I really didn't know. He's like, okay, we have a class starting on September and join in. I was like, okay, I'll join in. And what I got was, when you enroll, you get some papers to read, get some notes or something to read. I was hoping that, he's going to give me some notes or some presentation to go through. And what I got was 12 papers. And I was like, okay, again, 12 papers. 6 years into my practice, I was out of post-graduation, 6 year, there are 4 years then, and reading papers was very difficult because I come not from an academic background. I do not come from a research background. I was purely a clinician. For me, my goals was to treat my patients, to treat better for my patients. And when he gave me a paper, I was like, oh my God, I haven't read a paper in last 4 years. And reading those 12 papers was a task at that time. And then I attended a class, and then I thought this was enough, 12 was okay. He gave me another 14 papers. Okay, every week I would get another 8 papers, 10 papers, 4 papers, and then I lost the trail for some time. I couldn't actually get back to so much of reading within a week because we were not used to. And I started doing the cases, and then I realized that no, somewhere I have to draw the line. I stopped my clinic for 2-3 days. I sat down and I read all the papers, at a go, and those were those 128 papers that he gave me, and that was a moment for me because I realized what he taught me was not just something that is made up or that was, he thought that was a good technique. It was something that was really documented in the articles. It is not something that he was saying that, this is my technique, go do this. Everything had a scientific evidence behind it. Everything had a reason why he was doing it. And today I'm going to show you, I'm not going to share a lot of literature or anything. I'm going to show you some of the cases that I did in 2021 based on this 6 lessons approach. Can I have that, please? Yeah, it should work. Yeah. Thank you. So this is a picture. I was very lucky to be in US in May, and I had the opportunity to visit. Do you see those articles at the back? That's the basement of Dr. David. And I had the opportunity to actually see that basement and look into how much hard work he had put to bring those 128 articles to us. He had to read around probably 20,000 articles. 2,000, sorry, to get those to us. So, yeah, okay. Just a moment. David, do you want to check out what happened? Thank you. Thank you. So when we talk about restorative dentistry, I'm sure it's a very, very difficult field. I feel it's more difficult than endodontics, especially with the isolation and deep margin elevation and so much of tooth structure that we have to manage. So as a restorative dentist, we start at this point. We have to manage this. And also we have to manage something like that. And all of this comes under restorative dentistry. Now, for me, for a long time in my practice, probably this was pretty easy. But when it came to a loss of tooth structure, which was like this, and this, it started getting a little difficult. And root canal would be an option for me. When I was going very deep, root canal and crowns for cases like this, I would feel that root canal is the best treatment option. But when I did this mastership, the best thing that happened to me at my clinic was it opened up the whole dimension where I could manage very structurally damaged tooth, but they were still vital. And we did not want to do the root canal for them. So let's see some cases that we did. Okay, before we begin, this is an example which I take where people, dentists do not understand when we say decoupling with time or the hierarchy, which Dr. David will soon be teaching you in the next session. So the basic idea is there are two types of tissues, right? Majorly, we have enamel and we have dentine, to which we bond the composite. For a very long time, I was, kind of bulk filling them, put one layer or maximum maybe 2 layers and fill up my whole restorative cavity. Now what happens when you put a composite both together to enamel and dentine at the same time? So what I suggest is understand from the example of Fevikwik and Fevicol. Enamel is your Fevikwik and dentine is your Fevicol. Okay? When you bond to enamel, what happens is it sets immediately. Your composite will bond to the enamel and there'll be an immediate setting. You do not have to wait for some time. But what happens when you bond your composite to the dentine? Your dentine takes a little time. Remember, you've seen those carpenters take 2 planks of wood and put the Fevicol in between them. Have you seen carpenters using Fevikwik? No, right? They always use Fevicol. They put that 2 planks together and they tie it with the jack, right? And leave it overnight, yeah, for it. But next day, can you separate them? No. But is Fevikwik better than Fevicol? Definitely. Why would carpenters use Fevicol? Because it's better than Fevikwik, right? Same thing happens here. What happens is when you bond your composite to dentine, the bond maturation, the time that dentine takes for that bond to mature, like a Fevicol takes time to set, the dentine takes time for that bonds to mature. Whereas enamel, the bond sets quickly. So what happens if suppose I'm tying these two together with a piece of composite? My enamel bonds are bonding pretty fast, whereas my dentine bonds are still taking time to become stronger. Now, composite is a fluid, right? It moves. So what happens because it's bonded very fast in this zone, the composite starts moving towards the enamel and it starts getting delaminated from your dentine. And that is when you start getting that space. And now you have a submicron space. What will happen when the patient bites? There's a fluid coming out from dentinal tubules. And as the fluid moves in and out, the patient starts getting the post-operative sensitivity. Anybody who's not experienced patient's post-operative sensitivity in this room after doing a composite restoration? Anybody who says that my patients do not have had post-operative sensitivity? Yes, ma'am has, because ma'am learned this. Ma'am, I think you've been a pioneer in dentistry. Ma'am has been following all these techniques since very, very long time. Yes, so everybody follow ma'am. The reason why, how I can manage this is, I'm going to first put my composite only on dentine. Wait for some time for that bond to mature. Once that bond is strong, so that then I'm going to add my composite to the enamel. Now that bond to enamel does not have the capacity to move this composite away, because we gave it some time, extra time for it to become strong and mature. And how much time and more details will be shared by Dr. David in his next presentation. It's a very, very important concept. This is the basis of your biomimetic dentistry, and if you do not understand this, you do not go back learning. So everybody, now I'm just talking about two tissues, that's enamel and dentine, and you'll know more when he discusses. So let's see a case. A large caries restoration. Patient came to me with problems of food lodgement and also dislodgement of an old restoration. So what I assumed was there was a large amalgam restoration done 10 years back. And what happened, because there was a very large amalgam restoration, this cusp was quite undermined or weakened. And over the time, patient had a peripheral rim fracture. Remember Dr. Devi shared peripheral rim fracture, that it fractures at the sides because of the enamel or occlusal defect. It started cracking up, and eventually it got so undermined that the whole cusp fell off. So we started treating this patient, and we started doing our caries removal. We took help of caries detecting dye. And what I want you to learn from this slide is, can you see I'm starting to remove the lesion from outside? Yeah? We've been trained, in dentistry to go right in the center. Yeah? First thing we go right in the middle and try to get to the bottom of that zone, right? Things changed for me actually a lot when I attended these classes. I do not go in the center anymore. Start at the periphery, okay? You want to start at the periphery. You want to first create a very sound peripheral seal zone. Reach to a sound dentine in this zone, because this is a zone, that 2 mm or 3 mm of that sound dentine, which is going to give you the best of the bonding. All the articles that say, we can achieve 50 megapascals, 45 megapascals of dentine talk about sound dentine. Nobody talks about caries dentine bonding or, affected caries dentine at 45. So you need to have very sound dentine in this peripheral seal zone to get that kind of bond strength, and that is the bond that will keep your restoration in place, prevent that post-operative sensitivity for the patient. Now, once you've reached that peripheral seal zone, let's see a few more pictures. That's the caries indicating. You might need to apply an indicator for about, maybe about 6 times, 7 times, or maybe more. So don't get worried when you start. But always make sure in that peripheral seal zone, you've cleaned up all of that pink. So this patient had an occlusal effect caries, and we also removed the carious lesion from the proximal. He also had an opportunistic class 2 on 7, which we did at a later stage. And this is when I cleaned, once I did all my peripheral seal zone, I went in the center and cleaned up all the carious lesion at the center. Now, anybody can remember from the slides of Dr. Devi, from in the central stop zone, what would be your dimensions? Where would you stop? Anybody? Hilary, you know it. You've heard this probably more than anybody else. Yes, from the occlusal, 5 mm. From the proximal, 3 mm. There is no way I can measure from this point, okay? I can only measure from the adjacent tooth, right? So 3 mm starts from your adjacent tooth, okay? Always make sure, and always anatomically, this dimension, if you have a treated tooth, will change, will become 4 mm, okay? Your peripheral seal zone for a carious, for a deciduous tooth will become 1 mm, right? So the dimensions are important for a sound tooth, okay, for a normal anatomy. So if you have a patient who has an untreated tooth and you start measuring 5 mm for that, compensate for the loss of the tooth that has been there, okay? So I went ahead, and this is where I decided I have reached my 5 mm and I want to stop. So this was my central stop zone, and that was my sound dentine peripheral seal zone. Next step is good air abrasion. We are going to use dentine bonding agents, gold standard dentine bonding agents. So there are only two types of gold standard dentine bonding agents which is recommended. It's OptiBond FL and it's Clearfill SE system. Now these two bond systems are very, very different, and they require very different techniques. OptiBond FL is a total etch technique where you go in, etch your dentine, etch your enamel, apply your primer, and apply your bond. But in biomimetic dentistry, we are moving away from etching our dentine. We don't want to etch the dentine. We want to prime the dentine. So we go ahead and start using 6th generation bonding agents, which is your Clearfill SE bond. So in a Clearfill SE bond, you do not have a separate etch. Your primer is the one which is self-etch. You know, you apply the primer and you scrub it very well for 20 to 30 seconds. Let that self-etch of a primer go into your dentine and do its job. And you go ahead. But for that primer to work, you need to do the step which I did before, that is your air abrasion. Why? Anybody can tell me, any guesses why you want to do that? Increase the surface area? Yes. But yes, to modify my smear layer. If I have a very thick smear layer and I have a mild self-etching primer, will my primer be able to penetrate into the dentine? No, it will just work only over the smear layer. So to remove my smear layer and to compact all those Wick lock crystals, I take an air abrasion and I give it a good air abrasion. Now my smear layer is modified. I do not have that thick smear layer. I can go ahead and prime the dentine. I go ahead, do the priming, and once your priming is done, this is how you give it a good air dry for 10 seconds, and this is how your surface should look. It should look moist. It should look shiny. That is when you know that your priming is done. And if you do not see this, go ahead and prime for another 20 seconds. And once you're done with the priming, you apply your bond. Now, we all have learned that, apply the bond and give it an air dry, right? Everybody agrees? We apply our bond and give it a good air dry? Yeah? Here, we do not give an air dry because these bonds do not have solvent. Okay? We go ahead and apply it in a thin layer and remove the excess with another micro applicator. Okay? Do not air dry your bonds. We do not want to incorporate oxygen inhibition layer into those bonds. Okay? After this, you've cured your bond. Your timer starts for 5 minutes. And that timer is, why it started is, it's called as decoupling with time. Anybody, why we are going to now wait for 5 minutes? Exactly. Remember, dentine bonds take time to establish. We need time to make those bonds stronger. And that is the time, that 5 minutes that you need for your bond to become a stronger bond. So the only step that you can do in that 5 minutes is, which Dr. Davis spoke about, that is your resin coating. You take in your flowable composite, Clearfill Majestic Flow, or you can choose to use Voco Grandeur SO-Flow, and give a 0.5 mm layer of uniformly distributed 0.5 mm layer of composite. Not more than 1 mm at any point. Now when I say 0.5 mm, it's not just the base. It's all over the dentine up to your DEJ and slightly beyond your dentino-enamel junction. Okay? So it's just not in this zone. This is all dentine, right? So it will be all over your dentine up to your dentino-enamel junction. So once my resin coating is done, I finish for 5 minutes to get over, and then is when I apply my next layer, because I know my dentine bonds take 5 minutes to become stronger. Then I take a piece of fiber. This is a rebond, And I put it in a bed of Everex floor, and I wet my rebond, because sometimes dry rebond can be very difficult to apply. So I wet my rebond in a bond, squeeze dry that, and take and place it at the base of my cavity. So anybody, why does this give strength? Is it rebond is synonymous with providing strength, but at this point it has nothing to do with the strength. It has everything to do with the hybrid layer. I don't want that. That was a zone which was carious. I could not get to the sound dentine. Yes. Now that is going to have a poor bond strength to my hybrid layer, right? Not very strong bond strength in that zone. Now this piece of rebond in off on its own, or I'm doing it by mistake. Okay. Okay, it's okay. I'll work it. So now that piece of rebond, imagine a slab of concrete. Have you seen the construction people add a mesh of steel in that concrete slab? Right? That does something like that, but there it's more of reinforcement. Here it is more of creating a fail-safe mechanism. So what happens is composite shrinks, right? Everybody knows composite shrinks. And when I place that inert piece of fiber inside that composite, it counteracts that shrinkage. And instead of moving the composite away from the tooth structure, it actually pushes the composite towards the tooth structure. Now what is going to happen if my composite moves towards the tooth structure? What do I gain? Better bond, right? Higher bond strength. And this creates my fail-safe mechanism. So you will have people laugh out at you that why is that piece of rebond there, and do not worry about that, because you know you're going to have a very strong bond strength in that zone. Okay? Another reason, suppose XYZ reason, I did an enamel replacement and the patient bit on something very hard, and that onlay is going to fail. That rebond is going to protect your hybrid layer. It's going to protect your pulp. Whatever fracture you're going to happen is not going to go in that pulpal region. So you do not face catastrophic failures. Even if the tooth is going into a failure, it will be a failure that you can treat later. Okay? So that's the reason why and then after we've done our rebond in that Everex flow, I use either of the materials. The APX is the best dentine replacement, or Everex posterior, or Everex flow. If you choose to use an Everex flow, do not increase the thickness more than 1 mm, and replace all of the lost dentine. Now when I say replace all of the lost dentine, it goes both anatomically also. You replace up to your dentino-enamel junction and slightly beyond your dentino-enamel junction. And that is when you know that your bio base is complete. Remember Dr. Deve saying that you can leave the patient at this stage for 2 years? Yeah. I, at this point, pack my temporary because I'm already 1.5 hours that my patient is under the rubber dam. If I have to do the enamel replacement, it's going to be another 1 hour. So I pack in my temporary at this point, call the patient next day, and do my remaining enamel replacement. I went ahead, removed the carious lesions from the enamel. Remember, it's already cured, that bio base was cured. Now I want to regain those bonds. So I go ahead and give it a good air abrasion once more to my bio base, so that my next layer of composite can bond to that bio base. After doing an air abrasion, enamel needs etching. You cannot go with self-etch new universal bond systems which says that it's enough, you can just apply the bond and it will etch the enamel. Doesn't happen. So you have to have the etching of your enamel. So etch your enamel, and once you've done with the etching, go ahead, finish your composite restoration and do the 3-paper technique and do the bite adjustment. And that is the result that you'll get. And this patient, it's been 2.5 years, still good with that restoration. So this is a 3-paper technique. You see, when I apply on the non-working side, I start getting some more sliding contacts. Now, this is if I would not have stopped at that 5 mm, this tooth was going into root canal. Yeah. So now you know why the measurements are going to become very, very important. Next case. Okay, I still have grudges against my husband for this case. He scheduled me this patient saying, it's just a very small class 1, okay? It's going to not take more than 30 minutes for you, maximum 40. Okay, I said, fine, schedule him up. And you'll see why I was so annoyed. I started removing that lesion, and now, anybody if you see that, this is a magnified image at 25x. Suppose I was not using a microscope, yeah, I would definitely miss this. I would just leave it like that. I would just think that this is the lesion and that's all. But because I was using magnification and I saw that this is something that's showing up, I did not see the pre-operative radiograph for this patient. My mistake was that that half an hour started stretching to 1.5 hours. Okay? And that is when, sometimes when you will start out with this kind of treatment approach, my suggestion would be, to schedule your patients out for very simple restorative treatments, also for like 1.5 hours of clinical time. Because I was at this stage and I had 2 patients waiting in my operatory at that time for the next procedure. So now my husband doesn't do that anymore. He doesn't get to schedule my appointments. Yes, we went ahead, give it a good air abrasion. I was almost like 5.5 at this point, and I stopped. Any more than that, you can just leave all that pink there very safely, okay? You can just leave all that caries. Even if it's a very soft caries, just leave it there. Do not, if the tooth wants to survive, it will survive. The worst to worst that's going to happen is the patient may have symptoms and it will go for endo. So just prepare the patient for that. You had a deep caries lesion. You had a very soft caries that I had to leave behind. Suppose you get symptoms later, which usually, trust me, I've been into this now 2.5 years. Only patient that I had to do endo was a patient who actually gave me symptoms of pain. And because she was my family, I still didn't want to do her endo. I did BRD, and that's the only patient who ended for a root canal. So yes, I am here only because I saw better treatments for my patients, and this did give me a good opportunity. So I went ahead, give it an air abrasion. I'm going to go quickly now. Did the priming, did my bonding, did the resin coating, wait for 5 minutes. After 5 minutes, I used a small piece of rebond, placed it in the cavity in the bed of Everex flow, built up my rest of the bio base, the dentine replacement. And sometimes I want to do, the proximals can be difficult, and I want to do injection molding. I recalled the patient next day, gave it a good air abrasion, put in my matrice, but I only built up 1 mm of that proximal wall. Do not build up a lot of tooth structure or bulk fill it at a go. Build up the 1 mm and then did my edge enamel and replaced it by cusp by cusp. And that was the final result. Yeah. Okay, let's see another case. A large amalgam restoration, and this patient was not ready to get treated for this tooth. He was saying he does not have any symptoms, he does not have any problem, he does not want to treat this tooth. And I was like, I showed him this picture and I showed him, you see that it's starting to leak a little over there. And then is when he agreed for the treatment. I removed this amalgam restoration, and this was the situation below. So you go ahead, start removing all the caries tooth structure. Again, go from periphery, always from periphery. And then I started seeing that these cusps were going very undermined. So I put down my cusp so that I could have a better visualization and I could see better. And I started clearing all of the sound the peripheral seal zone to create a sound dentine. This case, I think I went up to 11 applications of indicator because it was very deep. But you will achieve that because there's no pulp in that zone and you're very safe. So go ahead and do that. Reach, and that was my caries removal endpoint. I achieved my caries removal endpoint, did my priming, did my bonding, resin coating, rebond layering, built up my bio base. I recalled the patient next day, did this deep margin elevation, and did my cementation for the onlay. Another case, this is a very nice case, and this case is close to my heart because I feel I put in everything that I learned in last 6 years into this case. Those cases, the last tooth in the arch can be sometimes, even the 7 can be a little buccally rotated. And they are the most difficult teeth to treat when you have a class 2 on them. So I was very well assured that I will treat this patient in 2 appointments. So first appointment, I'm going to do my bio base, and then second appointment, I'm going to do my enamel replacement. So first appointment, I put in a single isolation. Okay, because for bio base, I do not need to create contacts. I put in my single application of rubber dam, went ahead, manage the caries, try to reach my caries removal endpoint. It takes time. You go slow. You know, it's going. This is the step where you're going to take most of your maximum time. So caries, as Dr. David said, your lesson 1. If you master your lesson 1, 3, 4, 5, 6 is just a cakewalk. Okay, so spend most of your time doing this correctly. Get to the point. Try to achieve your peripheral seal zone. Clean it. Do your air abrasion, priming, bonding, resin coating, decoupling with time, and the bio base. So you see, I had the flow of the Everex on my enamel. Nothing to worry because you're going to expose back that enamel in the second stage again. Pack temporary at this point, send the patient off, recalled her next day, did a multiple isolation, used a smaller clamp because I knew I did not have another tooth at the end to engage my rubber dam onto. Used a premolar clamp. You see, I refined all my enamel margins again, gave in my bevels for enamel, did my deep margin elevation. At this point of deep margin elevation, I want to discuss something which is very, very important, which everybody misses out. Now, when you have a deep carious lesion, in this caul area, definitely your gum or your PDL or that caul is quite deep because there has been a food lodgement happening there and your bone recession in that area. But you know, most of you struggle to get your matrice in that deep margin elevation area. Yeah, everybody has had that struggle. I have had a lot of struggle getting my band seated in that area. And that is why that is happening is we do not understand that buccally and lingually or palatally, our gingival tissues are way much higher than only in that caul area. We are trying to go deep in that caul area, in that interproximal area, but buccally and lingually, our gingival, the height is much higher. So when we use the bands like this, which do not have a lot of gingival extension, this is the kind of problem you're going to experience, and later in your radiographs, you'll see that you do not have a very nice seal. So at this point, I just wanted to give this clinical tip away. Use for your deep margin elevations, use these matrices. These are available in India. In fact, I think TOR-VM is not available in US very easily. You can get them, but we have an easy access. You have an easy access. Buy these matrices which have, you know, the gingival extension so that you can, because this is not going to let these extensions seat your matrice deep in. And if you do not get any of this, go to a jewelry shop, ask him to give you a copper sheet. And then you can use small piece of copper and place that and use that. That is something I would do at the end if none of these are going to seat. Okay, so I did my deep margin elevation. So this band is one of those bands which are there in the picture. Did my deep margin elevation, got that deep margin elevation right, and then placed in my matrice, got that seated, did my etching. Now you see that this is a very, very large tooth structure to replace, and we don't want to add so much composite and let the C factor go uncontrolled. I went ahead and just built up very thin proximal wall. And that proximal wall, you don't want it to be more than 1 mm to 1.5 mm. And after I did the proximal wall, then is when I did my cusp by cusp build up. And that was my final restoration. Yeah, you see the tooth is slightly, this was a difficult patient. This can be challenging sometimes in clinic. And that was the post-operative IOPA. So you see, that's the reborn shadow that you see in the picture, and that's very close to the pulp. But I could treat such cases very successfully in my practice. And when I say success, I want to add on to this, minimal time, less discomfort to the patient, proper appropriate charge for the dentist. In India, when you do treatments like this, at one point, sitting out there, you're going to think, how much did I charge for that? I charged more than 10,000 for that restoration. That is when it's symbiotic and your patients will thrive, you will thrive, okay? Everybody back out there, I know when alumins finish their lecture, they come to me, ma'am, how much do you charge for these restorations? Because no matter what, in India, we all come down to finances. But when you record these cases and your patients start trusting you, you will be able to reach to that point. It took me time. Definitely, Dr. David knows how much struggle I had in my first year. I used to message him 2 a.m., 3 a.m. in the morning. I did this wrong, I did that, okay. Because there was nobody here to teach me, nobody here to guide me, or yes, besides Ankur. Ankur, my husband, is a prosthodontist. Okay, for him, root canal and crown, root canal and crown. And when he started seeing that I'm sending him less patients for crown, he got interested in learning these onlays and inlays. Yes, it's a true story. So, large composite restoration, and surprisingly, this patient got this restoration only 3 months back before he visited me. So I was pretty annoyed with the dentist, whoever did this. Okay, I started removing. This is a very nice case to understand the large treatments, you know, when you have a large defects, but not very deep, how you would go about them. Large defect, went in, tried to achieve my caries removal endpoint. You see how much these were undermined? I actually brought those cusps down, you know, those cusps. You might take around 1 hour. You may spend about, of that 1.5 hour, you may spend 40 minutes just reaching to this point. Because it's, as a biomimetic dentist, it's your duty to preserve all the good tooth structure also. So once we achieved our caries removal endpoint, we went ahead, gave it a good air abrasion, did my priming, did my bonding, did my resin coating, finished with my decoupling with time, gave it that 5 minutes for that bonds to become stronger. And then is when I started doing my deep margin. So this is something from, I don't know if you've seen this, from Garrison. It's called as Real Matrix. And these are matrices which are already prefabricated for deep margin elevation. So because I had a large volume to replace, I chose to use these matrices. And I did my air abrasion again after that and built in my margin elevation. Now, at this point, I realized that if I had to do an onlay for this patient, I will have to cut down this tooth structure, I will have to cut down this tooth structure, which I did not want to do, and I missed building my deep margin elevation a little higher. So I went ahead and did that again in the next step and got my margins a little more higher so that I would not need to cut away those tooth cusp structures. Because I want these to be really strong. They had a base which was having dentine, which is more than 3 mm, and you don't want to cut them down, okay? Otherwise, your onlays will start. So do not onlay the cusps which are very strong in them, okay? And then gave it a good air abrasion on the second appointment, did my etching, did my bond, and placed in my composite onlay. And that is, so my technician knows that he does not have to finish my composite onlays. I like to finish them after I have bonded. So this was an unfinished onlay that he gave me right from the milling, and that is the finished result that we had. Okay, I'm good to take any question if you have for a minute. Anybody? 1, 2 questions we can address at this point. You can just raise your hand and we will take it. Yes, please, go ahead. What happened? Oh, but it's connected to the, my computer is on. Okay, no problem. Question, please.
Hi, Doctor. Good afternoon.
Good afternoon.
It was indeed a beautiful presentation.
Thank you so much.
Uh,
I'm sure. Okay, okay. Yeah.
Doctor, I do have a question. What if we accidentally expose the pulp with a pinpoint exposure under rubber dam in such cases?
Okay.
What will be your recommendation, Doctor?
Okay. If you have a pinpoint exposure, there are 2 ways that you can manage them. First, you determine how much is your exposure size. Okay, if it's really small and less than 1 mm, just use a little hypochlorite in your applicator tip and hold it down. Hold it really down for at least a minute. That will stop that minor bleed that is happening. And once that bleeding stops, go ahead and just treat it the way you treat. Just prime, bond, and finish off your resin coating and finish off your restoration. Now, suppose you're very apprehensive to directly bond resin to your pulp. At that pinpoint exposure, and if it's slightly bigger, you can use a bit of bioceramic putty or an MTA or your biodentine only at that spot, not like a whole base. Okay, only at that spot, and then let it set for 10-20 minutes and then go ahead and do your priming body. So you do not have to wash, right? We are not doing etching at any point. We are not going to use water to wash this at any point. So you're not going to have that problem. The only thing you're going to do is air dry, right? So your MTA or your biodentine will not get dislodged. Okay? And then I'll show you a case where I had an exposure. I'll show you, I've tried to include different types of cases and loss of tooth structure so that you get an idea on how we manage these cases. Did we get it back? Yeah?
Thank you.
One more question I can take if anybody wants. Yes, please, go ahead.
Yeah, hi. Good afternoon.
Good
ma'am.
afternoon.
Can I know when the decoupling with time starts?
After you've cured your bond. Once your bond is cured, that is where your decoupling with time starts. The only step that you can do is resin coating. Okay?
Okay.
Okay, can we switch that off? Okay, so that was a finished restoration. Let's go ahead, and that was the occlusion check with the 3-paper technique. Very nice case. Actually, this composite was not very bad. The dentist did not do a bad job, but what he did was he did not understand the risk assessment. That is your lesson 2. Remember the lesson 2 where we spoke about cusp and the undermining of the cusp a lot? Now, do you see how thin that cusp is? Yeah, it's very thin, and this is the reason why this composite had actually started failing. So when I see how well that was bonded, you see the remnants? It's not that it just flicked off the moment I put in my burr there. So went ahead, keep measuring, always. You might, after 10 cases, you might think that you've aced at it, but I still have my periodontal probe right next to me. And something that I also use is the measured, sometimes you don't want to, and you've got that much practice, take the guide of your burr size as a measurement to how much deep you've gone, okay? Now, once I knew that I was almost 5 mm down there, I stopped at that point, went ahead, just cleaned the periphery, okay? I did not touch that zone at all. The only difference from this picture to this picture is the peripheral seal zone. Try to get an absolutely sound peripheral seal zone. And once I got my peripheral seal zone, I did my air abrasion. did my priming, bonding, resin coating, finished with a rebond at the base and built up my bio base, finished all of my dentine replacement. So you see, it was such a big cavity. So I, controlled the C factor by placing a bit here, and that is called as delibit technique, where you do not connect everything together and place, alibits and delibits small, and cure at the same time, because it saves you time. And then maybe connect at a setting. So we had one here, and here, which was not connected. And then once my bio base was complete, I brought this cusp down. And sometimes when you bring the cusp down before doing your bio base, what can happen is you can expose a little dentine there. And if you have a little exposed dentine, go ahead and redo all the steps again. Your air abrasion, priming, bonding. And I did that there. And once my bio base was complete, I took the impressions. We take digital impressions. And once the digital impression was taken, we send it for the lab to manufacture. And this point, I want to say, when we say bio base, what all does it include? Okay? You have your air abrasion, you have your IDS, your priming, bonding, your resin coating, and then your fiber in Everex flow or in APX or in Everex posterior, whichever you choose to, your deep margin elevation, and your dentine replacement. So all of this together is your bio base. And this is a point where you can send the patient off and not worry. Clear? And then, yeah, this was very funny, because sometimes you can have, when you place a thick rubber dam, you'll see before you placed in a rubber dam, your onlay was going, and once you place the rubber dam, your onlay doesn't fit anymore. Sometimes thick rubber dam have ability to cause movements of the tooth. So I placed in a matrice there and put in an Elliott separator to cause a little separation, and then is when I cemented my onlay in this case. That was the cementation, and that was my, after the 3-paper technique, I had some contacts, I cleared it, and then I did my finishing and polishing. So this was one cusp case. Very nice case, large composite onlay, very failing. You see, very tight contacts, very difficult to pass the rubber dam. I think I almost teared it. Let's go ahead and see this case, because I also want you to see different types of tooth preparations. We did this, removed the old composite. You see, we started seeing these peripheral rim fractures when we removed the old composite, because this cusp was very weak. And there was a lot of movement happening in this cusp, and the patient was experiencing sensitivity. So we removed all of the old restoration, got to a point where we brought that cusp down, cleared everything, got everything nice, clean, created a peripheral seal zone, stopped at the central stop zone, did a good air abrasion, beveled all my margins, did the priming, bonding, built up my bio base, and that was my bio base and the preparation for a ceramic onlay. And because at this point I knew I did not have very refined margins, but I did not want to cut down more tooth structure, I chose to keep it that way and fill it up with composite at a later stage. So next time patient came in, we always have a rubber dam whenever we are doing the cementation, did my etching, did my bonding, and we placed in our ceramic onlay. The reason why I could have gone with a composite onlay in this case, actually I prepped for a composite onlay. But my technician had come in and tell me, ma'am, I'm not going to give you a ceramic onlay on this case. I learned so much as I grew. And I asked him why. He told me, I have the scans of both upper and lower arch, and the lower tooth shows a crown on the lower tooth. And if you're going to place a composite against the lower tooth, it's going to get abraded. So he chose to give me a ceramic onlay, but the margins were good enough and he could create a ceramic. So your choice of restoration will depend. You can go ahead and do most of your cases with composite. I think Dr. David really likes when you do a composite, and the survivability of composite onlay to a ceramic onlay is not very different. But you will have to check things like that before you actually make a decision whether you're going to give a ceramic or a composite, okay? And also definitely the finances for the patient and the ability of your technician. Your technician should be able to give you exact margins and give you the thing that you really want. I had to struggle a lot with my technician. Very nice case and a very different approach that I did for this case. Usually if I would have been this like 4 years back, I would have started, at this point, trying to clear that away first and maybe bring that down. But I knew in this case that all the cusps are gone and I'm going to replace all the 4 cusps. So my first appointment intention was to just get my bio base right. And now when I have to get into bio base, the only thing I need to worry is not about these enamel out there and only about the dentine inside. So what we did was we went ahead, removed all of the dentine while used the old composite restoration as a well for that bio base. Okay? Because I knew that at a later stage I'm going to remove all of that for my onlay. So I went ahead, did remove all of the old composite, got to the point where the patient was still experiencing sensitivity a lot. So we went ahead, gave it a good, got my sound dentine, peripheral seal zone, reached my caries removal endpoint, stopped at that central stop zone, gave it a good air abrasion, did my priming, bonding, resin coating, used this piece of rebond right in that deep area, built that up and finished with my bio base. I sent the patient off at this stage, recalled him next day. Actually, I did this in 3 appointments because very delayed at that point. Recalled him next day and did my prep for a ceramic onlay. Once we did the prep, we did the etching and my technician gave me, we did the etching, we did the bonding and we cemented the onlay. So we use heated composite because it gives us unlimited time to remove all of the composite that you see around. You do not have that heart pressure and that beat where blood pressure and that beating where it's going to set and it's not going to set properly. I'm not going to be able to remove all my composite. Under your magnification, under your yellow light, you have unlimited time to remove all of your old heated composite, and that was a final restoration. So at this point, something that I would like to discuss is called as risk assessment, which is your lesson 2. And the key point to that is 1, 2, 3, 4. Okay? If you have a crack in dentine, do the crack dissection. If your isthmus is more than 2 mm in the width, you want to do an reinforcement, fiber reinforcement of your composites, bring your cusp down. If you have a cusp that is less than 3 mm, and where do you measure? Not at the top, at the base of the cusp, you want to bring that cusp down. And if you have a box, your proximal box, which is more than 4 mm in height, you want to do a deep margin elevation. So if you have a crack in the dentine, that is your 1 assessment. 2, if your isthmus width is more than 2 mm, it's a horizontal compromise. Your tooth is structurally compromised. 3, if your cusp of your width is less than 3 mm, it's a structural compromise. If your proximal box is more than 4 mm, it's a structural compromise. So if you have 1, you would want to do a crack dissection in your peripheral seal zone. If you have isthmus width, you want to consider a fiber reinforcement. If your onlay is less than 3 mm, you will consider doing a cusp capping. And if your proximal box is more than 4 mm, deep margin elevation is the way you will move towards. Okay? Another case, this is a case where I had the pulpal exposure, and the reason why I had that was because I actually lost the orientation in this patient. This patient had very tooth which was erupted, but the gums were very high. I don't know, passive eruption, what we call, where you have a complete eruption, but the gums are still very high. So I was little lost in my depth for this patient, and my orientation was very difficult. But when I started this case, I started off thinking that this tooth is not going to survive. It's almost a root stump, and there's nothing remaining in this tooth. So, but we never lose hope because he was just 13-year-old. So we went ahead, did our isolation, started, always, as I say, the mistakes that I did in beginning, and I try to correct them now. Start from the periphery, do not go right in the straight in the center. So sometimes, I have this picture because in such cases, I use a very big round burr also to remove them. And people is like, why do you have such a big round burr in your burr kit? So we went ahead, did my peripheral seal zone, and this is what happened. I got a small pulpal exposure because I did not take care that the patient was very young. And there is where, when you do not want your depth to be 5 mm and you would want to keep it like 3.5 or 4 mm, and I missed on that part. So I had a small pulpal exposure. I put in my tip, controlled that bleeding. The bleeding took a little time to control. So what I did was I put in a little bit of bioceramic putty and I let it set for a few minutes. And then is when I did my rest of the priming, bonding, and resin coating. And I'll tell you, I did not get this pulpal exposure when I did my burr. I got this pulpal exposure when I did my air abrasion. Yeah, sometimes, when it's very deep and you give it a very good aggressive, I was trying to get rid of that black there and try to get rid more and more. So I went ahead. The mistake I did was I did air abrasion for a very long time and that caused the pulp. So my burr was not the one which actually caused the pulpal exposure. So you can be, don't do aggressive air abrasions in such cases. We tried to remove that with air abrasion, and that's when I did it. So we went ahead, did the rebond, and I created my bio base. I did my bio base, bit by bit build up, and once I finished my bio base, now this was a very young patient, and I did a pulpal exposure, and his hygiene was really bad. You saw that tooth in the beginning. I was very apprehensive that this treatment is going to work for him or not. So I was very sure that I'm not going to give him onlay or anything at that point. So I went ahead and did my all of my build up, and I sent the patient off for 6 months. I recalled him after the 6 months, and I prepped all the margins again, and then is when I gave him a proper bonding and a proper onlay. So we gave him a proper onlay. And that was his final. We actually at our clinic we try and just not work on preventive techniques. We try a lot to teach them on oral hygiene, fluorides, flossing. So he did fairly good at 6 months in those aspects after cleaning, and then is when we decided we'll give him the onlay, or we would have again waited for some more time before giving that. Do you see how I was hanging in there? Yeah, and when you see so much of height, but actually clinically, the gum was at this point. So he was having some eruption, and he's now undergoing ortho treatment. And he's surviving. And this is the last case and the most difficult case which I think I did in my practice till now. This patient, I treated her for this tooth, and then I started seeing that there was a leaky restoration there, and we decided to change this old restoration. And little did I knew, and this is very early. Actually, I was still in my class when I treated this case. I had not even completed my lectures when I did this case. So I went ahead, removed the old restoration, and that is what, we do the structural, you do the structural analysis. Your lesson 2 goes in hand with your lesson 1, okay? When you're doing your removal, your tooth structural removal, your lesson 1 and lesson 2 goes together. It never separately. So you start doing your structural analysis, whether your cusp is weak or not. And at the same time, you would want to bring them down, because if they are weak, you will have a better visualization if you bring them down. And that is when I went ahead, I did, and this is what I saw. And and my stress level from this went to that when I saw so many cracks in that patient, because that was not something which I was expecting. And I was hoping that I just have to do a simple restoration. Okay. Now this turned into a case of crack dissection, and trust me, when you're going to go ahead and do a crack dissection case, as they say, that you can forget about lesson 5, but your stress is not going to go down when you come to the lesson 1. So there was a lot of structural compromise and a lot of cracks everywhere. So what we did was something called as crack dissection. And remember, you use, Dr. Davies showed that you use a small, long shank round burr to dissect the cracks. Now, sometimes very lost to understand what is crack dissection. So in your peripheral, what is your peripheral seal zone? Right next to your DEJ, 2 mm and 3 mm, your DEJ. So you remove all of those cracks in your peripheral seal zone. So there was a, you have to point, you know, at this point, and this point is where my crack is running in that peripheral seal zone, and do go ahead and do the crack dissection. And when we say crack dissection, we mean that we try to go to the bottom of the crack at that point. So in my peripheral seal zone, because there were so many cracks, you see, this point, this point, this point, this point, we went ahead and we pointed those points out and we did our crack dissections. Actually, I did it in this zone also. And we went ahead and did our crack dissections, you see. Now, the idea behind this is, when you have a cracked tooth, and you know, many people will have a lot of questions usually when they go back for this kind of technique, that is crack dissection, are you not creating a bigger trench? Are you not creating a bigger problems for yourself when you're doing a crack dissection? The idea is, you have a crack, right? Enamel, dentine and pulp, your crack is going through and through. And what is the problem? The patient comes with the symptoms of sensitivity when he bites. That is your main diagnosis with the crack. When he says that, you know, I don't have pain anytime. It's only when I bite the tooth that I get the pain. Now, you have a cracked enamel. Now, you went in that dentine zone and you created a trench and you filled up with a composite. Now, what is happening to the fluids that are going in and out in that crack? Now, you have a block of composite there, and no more the fluids are able to move in and out. That is where your symptoms of your patient stop when you treat this. Now, but the crack is there in enamel, but the crack is also there in the central stop zone. Now, if the tooth chooses to heal, it will start remineralizing in the central stop zone, because you do not have any more food, you do not have any more bacteria coming in that central stop zone, right? Which will still keep the pulp inflamed, right? So that is when you give a chance to the tooth to get remineralized and to stop paining for that patient. What about the enamel? Most of you have questions when we go back or we finish our presentation. Ma'am, what about this crack? Did you not remove this crack? Clinically, this does not have a lot of problem, because you have a bulk of composite and there's no way the fluids are going to go and disturb into the dentine tissue. So what I do is, when I see this kind of crack, I do not go all the way down, but I create around 2 mm of tooth structure in that crack and try to kind of put a good composite in that zone. So cracks in enamel are biomimetic, okay? They do not cause trouble, but cracks are dentine are the ones which cause trouble, right? So we went ahead. We were about 7.5 mm, and as I told you, I was still a student, and I'm still a student. I still keep learning reading. So at this point, I was stressed out. I could not take it anymore. As I say to him, I freaked out. Because, you know, everything is at standstill. You're literally sweating out at this point. You know, you want to stop. We stopped at that point. It was quite a big defect. Did our air abrasion. Once the air abrasion was done, because it was a very deep trench, remember, you cannot fill all of that together. So we took that first separately, put in a rebond, took care of that, and then is when we took care of the rest of the stuff. We put in a big piece of rebond, did our bio base, and once the bio base was done, we built in a proximal wall. So this was a patient where I would have actually given an composite onlay, but because we did not have that kind of discussion before the treatment, she was actually flying out. So I had to do a direct restoration. I built up her proximal wall, did my cusp by cusp building, and I left the tooth at this stage. I could have given a very beautiful anatomy, which I showed you in the first case. Remember the patient with the first cusp, where I went in, stained, and created a beautiful anatomy. I could have taken another 10 minutes and done that for this patient. But here I knew that the tooth was not that very strong. We did what we could the best. Here we created like a kind of saucerization and kept our cusp very simple, with simple anatomy, such that the forces would reduce, right? And we kept it very simple. And She's right now actually in Seattle, and I've asked her to visit you because she needs a follow-up, and she's fine. She's keeping very well on this tooth. So that's the reborn shadow. You see, actually I treated this tooth, and then is when I realized that I need to treat that too. To summarize, you need to assess the vitality of the tooth. So cold test is important. Then caries removal endpoint, your risk assessment, air particle abrasion, your bio base, your deep margin elevation, resin coating, decoupling with time, that's what I was getting confused. Your immediate dentin sealing, your decoupling with time, your resin coating, your bio base, again your air particle abrasion, very important. Why? Because anybody? Why is air particle abrasion very important at this point? Because you've cured your bio base, right? And now you're going to add more composite to it. So you maybe next appointment, so you're going to give it another air particle abrasion. Why? Okay, that's one point. Are you able to just selectively etch, or are you able to selectively just apply your prime only on dentine, give it an air dry and hope the prime doesn't go onto enamel? Doesn't happen. So you need to remove all that prime and bond from your enamel. So very important that you give that air particle abrasion and then continue with your enamel replacement. Yes, ma'am. So these are your steps for your bio base, and then enamel replacement. You would want to etch, bond, and start building up your composites in a small deli bits. Okay? Okay, this is going to come at the end, after Dr. Devi's presentation. Sorry. Thank you so much. And we'll have the questions at the end after his presentation.